Hello everyone. Welcome to the flashcard series. Without further ado, let's begin. So this is the first case. Take a moment to look at the sagittal T2 weighted image. We have two obvious findings. One is the peg-like cerebellar tonsils displaced into the upper cervical canal through foramen magnum without herniation of the brainstem. So tonsillar herniation is the inferior descent of the cerebellar tonsils below the foramen magnum more than 3 mm. Clinically, the presence of tonsillar herniation is often called coning. Another is the associated syrinx involving the cervicodorsal cord. So this is a case of Arnold Chiari 1 malformation. Chiari malformations are a group of defects associated with congenital caudal displacement of the cerebellum and brainstem. There are 7 groups of the same: Chiari 0, 1, 1.5, 2, 3, 4, and 5, out of which Chiari 1 malformation is the most common. So this is the next case showing reconstructed CT imaging of KUB. So what we see here are findings of dilated calluses with puddling of contrast, infundibular stenosis, and asymmetric ureteric wall thickening with multiple strictures. So these are our findings. To recapitulate some of the findings in renal tuberculosis, they are infundibular stenosis with caliectasis, moth-eaten calyx, parenchymal calcifications, cortical scarring, caseous masses, hiked-up renal pelvis, urothelial thickening, adrenal calcifications, central papillary necrosis, cortical abscesses, pharyngeal papillary necrosis, urethral strictures, beaded ureters, thickened bladder wall, granulation tissue, intravesical septations, urethral strictures, and mesenteric lymph node calcifications. Moving on, this is a coronal plain CT brain image showing subtle punctate basal ganglia calcifications. And there's also an evidence of a chronic lacunar infarct in the head of left caudate nucleus. So this is a case of mineralized vasculopathy. It's most commonly associated with congenital CMV, perinatal hypoxia, and chromosomal anomalies. The pathology being amorphous basophilic deposits lodging in the walls of medium-sized perforating arteries. An initial hypervascular vasculopathy can progress to perivascular mineralization. It is seen to frequently involve thalamostriatal and lenticulostriatal arteries. The risk of developing intraventricular hemorrhage and infarction is high. This can also be suspected in screening neurosonograms. This is the next case. What we're seeing here in the sagittal T2 MRI image is a rounded bony fragment lying above and anterior to the base of dens with no continuity with the body of odontoid. There's also evidence of atlantoaxial instability with narrowing of spinal gland and cord compression. So this is a case of os odontoideum. It's a skeletal don't touch lesion. There are two main types, orthotopic and dystopic. Orthotopic is normal position with a wide gap between C2 and the os odontoideum. Dystopic means displaced. It's also been termed os avis. Os odontoideum is often discovered incidentally on its own. Associated syndromes are Morquey syndrome and multiple epiphyseal dysplasia. It may be seen in association with another adjacent anatomic variant, the third condyle. The radiographic features are there's a smooth, well-corticated ossicle at the superior aspect of a hypoplastic dens. It's usually around half the size of a normal dens, and it's associated with hypertrophied and rounded anterior arch of atlas. The differential diagnoses are most commonly two. One, persistent ossiculum terminale, and two is type 2 odontoid fracture. So this is the next case. We're seeing axial CT sections of the abdomen and arterial face showing a cluster of small bowel loops in the region anterior to the left anterior pararenal space with air fluid levels within. So this image shows probable herniation of the small bowel loops through a congenital opening in the mesentery. So this is a case of paraduodenal hernia. Paraduodenal hernias Although uncommon, they have classically been the most common type of internal hernias. However, the incidence of post-op internal hernias has been increasing recently. So they may present with closed loop small bowel obstruction. Radiographically, left paraduodenal hernia will present as a cluster of small bowel loops in the left anterior pararenal space. The cluster of these small bowel loops is behind the IMV and behind the ascending left colic artery. Left paraduodenal hernias are commoner of the two types, and they herniate through the fossa of Lanzert, a congenital failure of fusion of the descending colon mesentery to the peritoneum in the left upper quadrant. Then we have right paraduodenal hernias, which present as a cluster of small bowel loops inferior to the third portion of duodenum. The cluster of these small bowel loops is behind the SMV, SMA, and the right colic vein. Small bowel herniates through the fossa of Waldeyer in right paraduodenal hernias. It's a congenital failure of fusion of the ascending colon mesentery to the peritoneum in the right lower quadrant. They are most commonly associated with small bowel malrotation. So this is our next case. We're seeing axial sections of CT pulmonary angiogram showing an intraluminal hypodensity straddling through the bifurcation of pulmonary trunk, extending into the right and left pulmonary arteries, more so on the left side. So this is a case of saddle thrombus. With such an extensive embolic burden, signs of right heart strain should also be looked out for, which are the dilatation of right ventricle, straightening or leftward bulging of the intraventricular septum, enlargement of the pulmonary trunk, and contrast reflux. Here we have another case, T2 axial sections of the brain showing communication of the frontal horns of bilateral lateral ventricles. There's also absent cavum septum pellucidum. T2 sagittal sections of the brain are showing a hypoplastic optic chiasma and hypoplastic pituitary stalk. So putting these two findings together, this is a case of septo-optic dysplasia. This is also known as de Morsier syndrome. It's characterized by optic nerve hypoplasia and absence of the septum pellucidum. In 2/3 of the patients, hypothalamic pituitary dysfunction is present. So the DDs for septo-optic dysplasia is agenesis of corpus callosum. So we try to look out for the racing car sign. Another DD is open lip schizencephaly. Another DD is lobar holoprosencephaly, which may not be very easy to differentiate. So we need to look for the cerebral anterior artery, which will have a course shifted more anteriorly in lobar holoprosencephaly. This sign can also be looked out for on prenatal ultrasound in the midline sagittal view with color Doppler. And optic chiasma is not expected to be hypoplastic in lobar holoprosencephaly. So this is our next case where we're seeing a nidus of vascular channels that are prominently appearing to be venous, caudal to the mid-third of the superior sagittal sinus. So this is a case of brain arteriovenous malformation. The Spetzler-Martin arteriovenous malformation grading system allocates points for various angiographic features of intracranial arteriovenous malformations to give a score that predicts the morbidity, mortality, and risk of surgery. So the grade is equal to the sum of points in 3 categories for a minimum of grade 1 and maximum of 5. And there's a special designation of grade 6. So the 3 categories are size, eloquence, and venous drainage. So the size is basically defined by the largest diameter of the nidus on angiography. Eloquent areas of the brain are sensory, motor, language, or visual cortex. Also, we have hypothalamus and thalamus, internal capsule, brainstem, cerebellar peduncles, and deep cerebellar nuclei. The venous drainage pattern is divided into deep and superficial based on where they drain into. The presence of a deep drainage system complicates excision due to poor surgical accessibility compared to a malformation where all the drainage system is via the cortical venous system. The special category grade 6 is defined as inoperable, in which surgical resection would almost certainly cause total disability or death. So the score ranges from 1 to 5. Lower the score, better the outcome. There's also a supplementary grading to this grading system. Moving on to the next case, we're seeing an axial DWI image of the brain with evidence of a punctate focus of diffusion restriction in the lateral edge of the hippocampal gyrus abutting the temporal horn. So this is a case of transient global amnesia. The maximum detection is seen within 48 to 72 hours. It's a clinical syndrome with no clear etiology identified, and most symptoms are transient and resolve within a few hours. So these lesions can be bilateral and even multifocal. This is the last case in our flashcard set. So we're here seeing axial T2 sections of the lumbar spine showing peripherally placed nerve roots within the thecal sac, producing an appearance of an empty thecal sac sign. Note the post-op changes in the lower lumbar spine. Here we're seeing clumping of nerve roots with the thecal sac, forming an enhancing soft tissue mass anteriorly at the L5-S1 level. So this is a case of spinal arachnoiditis. Most common cause is iatrogenic spinal surgeries. Although arachnoiditis can be present throughout the subarachnoid space, it is most easily seen in the lumbar region where the cauda equina usually floats in ample CSF. So there are three types. Type 1 is when the nerve roots are clumped together and distorted. Type 2 is when the nerve roots are adherent to the theca, resulting in an empty thecal sac sign. And type 3 are nerve roots in the theca clumped together into a single soft tissue mass centrally within the spinal canal. The main differential diagnosis is leptomeningeal carcinomatosis. Thank you for watching. Hope the video has been useful to you.